I'm back.
All right, we will wait just a moment before we get started. All right, and before we get mo started, you'll see these two QR codes on your screen for our pre-event surveys. And I will also be dropping these links in the chat. We have one survey for patients and caregivers who are joining us today, and then a separate survey for our healthcare providers. So if you could just take a brief moment to complete the one that applies to you, we'd really appreciate it. All right. Let's go ahead and get started then. I am so excited to dive into today's topic on celiac disease and irritable bowel syndrome, and we really have a fantastic group of speakers joining us today. And then again, for those of you who may just be joining us, these two QR codes on the screen are for our pre-event surveys. And I'll also share those links in the chat if they're not already shared in just a moment. So please feel free to complete whichever one applies to you as we get going here. And before we begin, I just want to quickly review a few housekeeping items. So, first, a very big thank you to Schär and Ardelyx for their generous support of sponsoring this culinary medicine webinar. We really do appreciate their support as this would not be possible to provide to you all without them. And we do also have translations available. I believe we have the one in Spanish. Do we have Portuguese working? No, we don't. I know we're having a technical difficulty with our Portuguese interpretation, but I know we have our Spanish live interpretation available. So to access that feature in Zoom, you can click that globe icon that should be towards the bottom of your screen. And you can select Spanish if you would like to listen to that. And then you can listen to this presentation from our live Spanish interpreter. And also for our healthcare providers joining us who would like to claim continuing education credit, we just have some important information for you. I'll review these instructions again at the end of the session, and you're always welcome to reach out to me afterward with any questions. But here are the instructions. So if this is your first time attending one of our sessions, you will need to register and create an account through Boston Children's Hospital using that link that's on the screen. And once your account is set up, and your mobile phone number is included on your profile, you can text that code on the screen, P8BKE, to that phone number shown to log your attendance today. And if you joined us before and already completed those steps previously, you can simply text that code to that phone number, and then you will all will receive a confirmation once your credit has been awarded, and you can also download your transcript by logging into your account. And for our dietitians, just a quick note, the documentation you'll receive is a transcript, which may look a little bit different from the traditional RD certificates that you may be used to receiving, but it is an acceptable form of CDR documentation. And again, I will be sharing all of this information in the chat shortly, and also we'll go over it again at the end. But if you do run into any issues or have any questions about continuing education credit, please feel free to reach out to me. And our topic today is untangling the gut, IBS and celiac disease from clinic to kitchen. And we are joined by an excellent panel of speakers today. And as with all of our culinary medicine webinars, you'll hear from a gastroenterologist, a registered dietitian, and a medical chef, really bringing in a variety of expert perspectives. And we may have some time towards the end for our speakers to take some of your questions. So if you do have a question during the presentations, please send it our way using that Q&A button that should be towards the bottom of your screen. So with that, I am delighted to hand it over to our first speaker, which is Dr. Pinto Sanchez, to get us started.
Thank you very much, Emma, and for inviting me today. It's a pleasure to be here. Can you see my slides now?
Yes.
Yes, great, great. As I mentioned before, it's a pleasure to be here and to discuss a topic which is quite challenging for managing, not only for patients but for physicians as well, which is IBS and celiac disease. So the agenda for today is we're going to review what is the difference between IBS and celiac for those who are not aware about both conditions. We're going to see what tests are available to differentiate both, and if there is any link between celiac and IBS, and whether we should screen for celiac disease in IBS. And all these topics are going to be, and I'm trying to bring you the most most updated research evidence. So to begin with the definition of each of these conditions, celiac disease and IBS are both different conditions with different pathogenesis, different definitions, but they share some symptoms in common. And those symptoms that they share are gastrointestinal, which is mainly abdominal pain or discomfort based on the most recent definition, bloating, gas, and constipation and or diarrhea. So there is a change in bowel movements most of the time for both. However, in celiac disease, we can see other features that are not typical of IBS. Whether it could be present, they are not typical. For example, if someone is losing weight, if they have some red flags like iron deficiencies, nutrient deficiencies, if they have other extraintestinal symptoms like migraine, joint pains, those are more typical of autoimmune and celiac. Reproductive issues, osteoporosis as a complications of celiac usually is not a typical complication in IBS, or skin rashes, for example. Those autoimmune are more typical of celiac and not just of IBS. So, but we should also have keep in mind that celiac can present without symptoms. So there is no one single symptom that defines celiac disease, as we all know. That's what is called the clinical chameleon. The frequency of celiac disease, both of them, celiac and IBS, are frequent conditions. Celiac affect around 1 in 100 of the population. Of course, there are the different prevalences or different frequencies in different countries and different cities, but this is just in general. IBS is way more frequent. It can be present in 1 out of 10, and even in some countries in 20%. So 1 out of 5 people may have IBS. So it's way more frequent than celiac. So in terms of mechanisms, what is producing one or the other? So in celiac disease, we know that it is an immune-mediated condition that is triggered by gluten. Actually, it's is driven by gluten and happens in genetically predisposed individuals, which means that to develop celiac disease, we need a genetic predisposition. So we need almost like a 99% of people or 100% of people with celiac, they will have this genetic predisposition. And then we have the driver, something that is a trigger, for example, a virus infection, and initiate this first immune reaction. And then the gluten is a driver of this immune reaction. And that leads to inflammation in the gut, as you will see there, with shortened villi in the small bowel. However, in IBS, the definition is not that clear, which meaning that is based mostly in symptoms, but there is no objectives, markers or objectives, affections in the gut. So there is no organic cause of IBS that we can see in the gut. So there is no clear genetic predisposition for IBS. Some people may improve. I will touch on this a little bit. Some people may improve on gluten-free diet, but does not necessarily mean that gluten is causing or triggering IBS. And definitely there is no gut inflammation that you can see. There may be a low-grade inflammation, with very specific tests, but not something that you can see as in celiac disease. So the definition of IBS is mostly based on clinical criteria, so symptoms. So how it is defined? Is any abdominal pain IBS? No. It has to have a frequency more like, like a regular frequency. Of course, is intermittent. That's one of the characteristics of IBS, is cyclic, but it has to be like some frequency on a weekly basis, and it has to be associated like this abdominal pain or discomfort that happens several times in a week, and is associated with some changes in bowel movements, changes in stool frequency or the form of stool, and it has to be chronic, not something that just started this week or last week. It has to be, that is more than 3 or 6 months. And this is the new definition that is called Ron-Frey criteria. Both of them target the gut, right? So, of course, the gut is long and starts in the stomach, then it's followed by duodenum, which is the first part of the small bowel. Then you have 3 to 6 meters of small bowel and ends up with the colon, which is 1.5 meters, and the rectum, that's the more distal part of the gut. So celiac disease affects mostly the proximal small bowel, which is duodenum, and the proximal jejunum. That's why when we do an upper endoscopy that looks at the duodenum, we will see these features most of the time of celiac disease, that is shortening of these villi. As you will see on the left of this graphic, this is a healthy gut with villi that are tall and thin, and the right you will see those flat villi, which is typical of celiac disease. It may be patchy or not, but usually in most of the cases affect the proximal small bowel. In IBS, if we do the endoscopy, we will see nothing. And if we do colonoscopy, even affects mostly, the colon or the contractions of the bowels, we will see nothing. So, and this is why it's not that it's shortening of villi in the gut or inflammation or ulcers. No. We're not going to find that. What we're going to see is that there is a change in the contractions of these bowels. Can be some small bowel, but mostly the colon. And it slows down too much, and sometimes that leads to constipation, or it accelerates the transit that leads to diarrhea. And that's why there is IBS diarrhea, IBS constipation. Some people may have a mixed pattern, and some people may have you cannot say one or the other. They may have sometimes one or the other. And how we can diagnose these conditions? Well, in celiac disease, I mentioned before, and I show you how the short villi can be found when we do the upper endoscopy and we take some biopsies of these samples from the small bowel. We will not see that in IBS. I already mentioned that. And what about blood tests? Well, most of people with celiac disease are diagnosed through blood test, which shows a positive serology specific for celiac, which is TTG, antinomysial, or DGP antibodies, which are again, very likely to be highly positive in celiac disease. In IBS, those markers should be negative, so they should be absent or within normal range. Then also we have the genetic. If we test a gene, this HLA-DQ2, DQA in celiac, the majority of celiac will have them positive. In IBS, it's tricky because, yes, some people may have it positive, but doesn't necessarily mean that the genetic predisposition will lead to celiac. So then it could be either positive or negative, and that's not used to test for IBS. And what about response to gluten-free? Many of my patients say, oh yeah, I have celiac because my symptoms completely went away when I went gluten-free. Well, unfortunately, that's not specific for celiac either, right? So many people with celiac, they feel nothing when they stop gluten, but that doesn't mean that the gut is improving, right? So that's why response to gluten-free diet is not, it can be positive or negative in both celiac and IBS. So it doesn't help us to differentiate both. And what about the gluten challenge? Well, if someone with celiac that has been on a gluten-free diet for a long time, they go back and eat gluten, they will trigger again the inflammation and these blood markers. That doesn't happen in IBS. So if someone with IBS, they improve symptoms and they decided to go gluten-free for years and then they eat gluten again, they may have some recurrent symptoms or not, but they will not have any inflammation as before. So unfortunately, we have a very clear way of diagnosing celiac. We don't have a very clear way to confirm the diagnosis of IBS. It's mostly based on clinical and ruling out organic disease. And how diet plays a role in IBS and celiac? Well, we know that many people with celiac disease have symptoms triggered by gluten. Others, they don't have symptoms, but all of them have gut inflammation triggered by gluten. So symptoms are not directly triggered to the diet, but inflammation it is. In IBS, over 80% of people, they report some food trigger to their symptoms. So in celiac disease, the only available treatment is to remove completely gluten from the diet. In IBS, yes, it can be treated with diet, but because we have to manage symptoms, we can also give some medication to manage the most concerning symptoms. In celiac, the gluten-free diet, which is also wheat-free, rye-free, barley-free diet, but in IBS, the drastic reduction of gluten and the improvement related to symptoms may be due to other components than gluten. It may be, for example, due to carbohydrates, it may be due to fiber, it may be due to other components, other proteins in gluten. We don't know why they are improving their symptoms. We know very well that in celiac, it requires completely removing of gluten until something, I don't like to say for life actually, but until something comes up. That's the only available treatment, and it has to be indefinite. Because even cross-contamination can cause not only symptoms in some people, but also inflammation. However, in IBS, yes, even if they go gluten-free, they may not necessarily have to be like a very strict gluten-free diet, because again, we don't know that exactly gluten is causing that, and many times when they get contamination, they don't have this recurrence of symptoms, so it doesn't have to be that strict. So these are different relation of celiac and IBS with diet. What we must know is that celiac and IBS can overlap. Sometimes you can have both. You have a person that was diagnosed with celiac and then later on with IBS, or vice versa, someone that was diagnosed with IBS and later on with celiac disease. So you can have both of them. So what is the frequency of IBS in someone that has celiac? Well, 38% of people with celiac disease may present IBS symptoms down the road, despite strict adherence to gluten-free diet. But it's more frequent to present symptoms in someone that don't adhere. But doesn't mean that if you are very, very strict, you cannot have symptoms. Yes, it's very, very frequent. And 1 out of 5 people with celiac meet criteria for IBS, even if they're doing a gluten-free diet. In IBS, the frequency of celiac disease is significantly higher than the general population. As I mentioned before, is 1 in 100 like an average. In IBS, if you have IBS diarrhea, it's almost 6 times more frequent. If you have IBS mix, is 3 to 4 times. IBS constipation is at least 2 times more frequent. And that's why the average of celiac in IBS is around 4%. So what are the recommendations to diagnose celiac disease? So I have many of these questions. I say, I have IBS, should I get checked for celiac disease? And the answer is yes. So it is very well recognized because of this highest prevalence of IBS in celiac. And celiac in IBS, that is 4 times more than the general population, its recommendations are for people that have IBS is to check for celiac. So after excluding other conditions leading to symptoms, for example, cross-contamination, SIBO, like many times people have symptoms despite being gluten-free, so then the doctor usually do some tests to rule out other issues related to celiac disease, as I said, SIBO, inflammatory bowel disease, sometimes pancreatic insufficiency, bile acid malabsorption, and then when everything is about normal and you cannot find something else, then we start thinking about IBS. And then your doctor may give additional treatment for management of IBS symptoms on the top of gluten-free. And what about celiac diagnosis in IBS? Well, TTG is recommended, as I mentioned, in IBS, especially in diarrhea. As I showed you before, is way more frequent in someone that has IBS diarrhea to be diagnosed with celiac disease. And the reason why it's recommended to test for celiac in IBS is not only because of the increased frequency, but because you have a treatment. And someone that was not doing a strict gluten-free diet, didn't know they have celiac disease, now they are diagnosed with celiac, and then they can be having access to treatment. And so that treatment is highly effective to decrease inflammation, and we know that. And it may help controlling symptoms if someone was misdiagnosed of IBS and actually they had celiac disease that was undiagnosed. So what about the dietary treatment for celiac and IBS? So I would like to bring you this study that was years ago, over a decade ago. This is the first study showing that gluten may cause some symptoms in people with IBS. I'm talking about pure IBS, not celiac. The TTG was negative. They were ruled out celiac, but they went on gluten-free diet, and in these people, when they were getting gluten, the symptoms were triggered, and that's compared to placebo. They were doing gluten-free and then challenge. So people who got the placebo were significantly lower symptoms, and people who had gluten, they had higher symptoms. So I said, okay, so then there is some trigger of symptoms by gluten, and that was the first study. And I will tell you, they found out different things after, but this gluten trigger symptom of IBS has been going around for at least 15 years. And there has been multiple studies and trying to find out whether that's gluten or other dietary targets, for example, carbohydrates or FODMAPs or fiber, that was actually triggering symptoms in people with IBS. So we very recently did a study that was led with Dr. Berchik and this very talented PhD, and she's Caroline Seiler, and was co-supervised by me, and she did her PhD on this study evaluating triggers of symptoms in people with IBS. So the people with IBS, with very well diagnosed and targeted IBS and very well investigated, non-celiac, they were randomly allocated to receive whole wheat plus gluten, pure gluten, or gluten-free completely bars. And almost one out of 1/3 of these people, they took these bars, and they took at different points. Everyone took the 3 bars, and they didn't know what they were receiving, right? They were blinded completely. And as you will see there, 11 out of 28 people, so 1/3 of these patients responded to gluten, so the gluten triggered the symptoms. 1/3 of these patients was wheat, other components of gluten, but in 1/3 of these patients, 8 out of 28, it was nothing even gluten-free trigger symptoms. So there was no relation with gluten whatsoever. So what we saw in this study, that there was a very high nocebo effect. So people that were anticipating that the gluten was triggering their symptoms, even though we showed that there was no gluten, they were still perceived that symptoms were triggered. So we found very high nocebo effect. The other thing that we found is that some of these patients were not specifically compliant. They were still getting some gluten when they shouldn't. And so that's another factor that interferes in the results sometimes, if you don't get like 100% of compliance, or you get some component that is altering the result. But one of the things that we found out is that in people who believe that gluten was triggering their symptoms, even though we disclose the result and show them that nothing and symptoms were not triggered by gluten by taking gluten, they decided to continue gluten-free. So what we show in this study that was published in a very high impact journal is that persistent belief that gluten caused symptoms may affect some people that have gluten reaction. So the reaction with gluten in people with IBS is a little bit tricky, and sometimes it can be the belief that gluten is causing symptoms. So we were working with Dr. Berchik on this for years, for a decade, and trying to identify people who with IBS that will benefit from a gluten-free diet, because we didn't want to put everyone on gluten-free, right? And in this study that we published a couple of years ago, we were able to identify that people who responded to the gluten-free diet positively, they had also a marker that there was some immune reactivity, that is a low-grade immune reactivity, and this marker was identifying that. So in future, we will be able to identify which people with IBS should go gluten-free and who is not necessarily going to benefit from that. And the reason why I told you that the first study on gluten, and I told you that initially the separation was very clear, the same group later on found out that it was not gluten what was causing actually their symptoms, it was FODMAPs. Because when they control FODMAPs, which is a fermentable carbs, and I'm going to show you now what is that, so they were not able to separate the difference between gluten and the benefit of gluten anymore. So the same group that was initially saying gluten caused symptoms in IBS, they later on found out that it was mostly driven by FODMAPs. And what are FODMAPs? Well, those are complex carbs that are difficult to digest. So our gut doesn't digest very well, and those are contained in many foods like garlic, beans, onions, and within others. And then, because they are not digested in the small bowel, they come to the colon and the bacteria are waiting for them to digest them. And when they digest these complex carbs, they break down and produce gas. And that gas produces bloating, distension, pain, constipation, sensitivity, and some people develop these symptoms for a long time. So this low FODMAPs diet has been proposed as an alternative, as a dietary treatment in IBS. And there has been many studies on this. And there has a very recent publication, and the citation is at the bottom of this, on it's called an umbrella review that evaluated multiple studies on the effect of low FODMAP diet in irritable bowel syndrome. And they included 192 studies that were published until last year. And what is I brought you this just to put this in context. What is an umbrella review? It's a term that may be new for many of you. As you know, there are different studies that we do to prove efficacy of a therapy. And in this pyramid that you will see there, umbrella review is the top of the evidence. And why is that? Because include pool data, like all data for many systematic reviews. So you can start from the lowest evidence at the bottom. You'll see if someone says, oh, this diet is effective based on opinion, that's a very low level of evidence. So we don't consider that scientific evidence. Case reports, so based on one experience of one person that is very well studied by a scientist, it's at the bottom of the level of evidence. We consider very low evidence, okay? Then when you have, okay, that's interesting, but we cannot say that that's effective. Then you have case series, so that happens. When the expert opinion, when there are no studies, just expert. Case report when it's just one single case. Case series when there are few cases, like up to 10 cases. That says, okay, 10 people, based on 10 people or 8 people or 5 people, we see this improvement. Okay, there is a signal, but you cannot see that something really, there is evidence at work, even if it is published as a paper, right? Then you have observational studies that usually are more than 20 people, that there are no intervention, you just see or compare two groups, a group that is treated with something and a group that is not, and then you see that this group improve or not. Those are observational studies. And then you have what is called systematic review of observational studies. What is a systematic review? Is pulling multiple studies or all studies that were scientifically searched with scientific search, and they were pulled all together and say, okay, based on all the studies that meet our criteria right now and were published until now, we have this outcome. And then we have randomized controlled trials. Those are high quality level of evidence because those are studies that they remove the belief because they compare a treatment with no treatment. And then usually that's by chance. So the person that participates has the same chance to receive the treatment or the no treatment. So the results are based on less bias. And then you have the systematic review of those randomized studies. That's pooling all those studies. That's the highest levels of evidence. And then you have the umbrella review, which is pulling all the systematic reviews. So it's a review of systematic reviews. So there is a lot of data from umbrella review. So what is this umbrella review has to say? So this umbrella review on low FODMAPs diet show that 16 meta-analyses, 16 systematic review with meta-analysis with very, very well-analyzed data, show, including 141 studies with almost 10,000 people with IBS, show that low FODMAP diets can help some people with IBS feel better, so improve some symptoms and improve the quality of life. However, the effect was moderate, so it's not like a completely relief, and not in everyone. So it did not clearly improve symptoms like belly pain or constipation, right? So low FODMAP diet is not very good for people with constipation because there is no evidence that will help improving constipation or significant abdominal pain. It's more bloating, but improves our overall symptoms. But one important thing is I show you our study that accounts for this nocebo effect or belief, right? So this systematic review and all these studies that were published, they were not blinded and they did not account for the belief, which is a big problematic because some people that improve, they improve because they believe that they improve, and it's something that affects the studies. So you should interpret these results carefully and have always in mind that psychological factors may play a role in dietary treatments in people with IBS. And that happens because you cannot blind easily a study, you cannot blind the diet, people know what they're eating, so it's very hard to do a study blinded, and then there may be some bias for this placebo effect. So what happens of low FODMAP diets in celiac disease? Celiac disease is different because you have an outcome, right? So it's on the top of that you have symptoms, but also you have celiac, and you need to make sure that gluten-free diet is done very well. So it's more challenging to do gluten-free and low FODMAPs, right? On the top of the low FODMAP diet, what you have to restrict gluten as well. So there is a systematic review, now you're familiar with this term, of low FODMAP diet in celiac disease with persistent IBS-like symptoms. So people who were following gluten-free, but they still had persistent IBS symptoms, they were still struggling with abdominal discomfort, belly pain, with the changes in bowel movement. So 4 of these studies, 2 randomized controlled trials and 2 open labels, will mean that they were not randomized, people were getting the treatment, but they knew what they were getting, okay? And they were comparing the low FODMAP gluten-free to regular gluten-free diet in 115 people. And they found that they may improve some bloating, distension, in people with celiac disease, but same findings. Is not everyone, is not constipation, is mostly bloating, and the quality of the evidence, because this open, people were knowing what they're eating, you cannot control for these psychological factors, then the quality of the evidence was rated low. So it may improve, there may be a signal, but there is no strong evidence. And why we're worried about the strong of evidence? We say, okay, if someone just feels better, why don't just give it? Well, because we're worried that restrictive diets can lead to nutrient deficiencies and changes in gut microbiota. So gut microbiota, as you know, it can be healthy and unhealthy, and restricting diet may lead to unhealthy changes in gut microbiota. That's why it's important to any diet is supervised by an expert. And another thing that I didn't mention is that the low FODMAP diet, I think Megan will touch on this, requires different stages, and one stage is a short-term diet, and then after that reintroducing the foods, trying to reduce the restriction. That's a critical phase, but not everyone does, especially when people are not supervised. That's why it's so important to get supervision and go to the next step. And adhere to a diet outside of a clinical trial setting, it may be more challenging, and there is a risk of what we call stacking diets. People may feel very overwhelmed of doing all this restriction, but also for us as a physician, dietitians, there is a paper recently published showing that how challenging it is for us also to recommend on stacking diets, because what people eat when they restrict so much, right? And also we need more evidence on what happened in the long term with all these nutrient deficiencies, with the effect, how people are feeling, are they healthier, non-healthier with all these changes, right? So we really need this evidence. And this is how it look like, like a low FODMAP diet and gluten-free will look like. those are the food that you can eat, those are the food that you cannot eat, but it's always recommended to be monitored by a dietitian because it's a lot that you cannot do and then over restricting is problematic. So what are the take-home messages? Celiac and IBS are common and they may overlap, but we should rule out celiac disease before diagnosing IBS. So if you have a friend or someone that has IBS, I said, did you get checked for celiac? Okay, especially if they have diarrhea. A gluten-free diet treats everyone with celiac and a small proportion of patients with IBS. A low FODMAP diet is first line for IBS and may treat a small proportion of celiac that have persistent symptoms. Not everyone, and it's not a healthy diet to do. We should avoid unnecessary dietary restrictions. Very important to have an accurate diagnosis, and dietitian support are key to safe and effective management of both conditions. Because we're worried about the stacked diets, stacking one out of the other, and they have some challenges for patients, for physicians, for families, and may lead to nutritional deficiencies. And people may become less healthier after this diet. That's why it requires a dietitian guidance. I'm lucky to work with a very good team, a nutrition initiative. We're very highly focused in nutrition. I'm lucky also to be a support and collaborate with Celiac Canada, with Celiac Disease Foundation. And you are also lucky to have this CDF looking after you as well. So thank you very much for this opportunity. And after, when Emma says, I'm open for questions.
Okay, thank you so much. I'm just gonna share my screen. Okay. So, hi everyone. My name is Megan Donnelly. I am a registered dietitian and I do have additional credentials in GI nutrition. So, the CSDH after my name is now in the United States the indication for a GI credential. And so, a lot of what I'm going to talk about is complicated in terms of managing the diet, as Dr. Pinto Sanchez just pointed out. And so, if you're looking for a dietitian who may be more experienced in this, in celiac disease, in IBS, in low FODMAP diets, look for that CSDH certification because that's someone who has an advanced practice credential in the United States. Okay, so I think what Dr. Pinto Sanchez said first, understanding what your symptoms are, what is causing them, and keeping in mind that not all digestive symptoms are related to gluten. It can be hard to determine whether or not your symptoms are related to celiac disease or gluten, especially if you have not been following up with your healthcare provider team, working with a dietitian. It can be a little bit challenging. So I always encourage you, if you're struggling with what to do in order to navigate this, keep a food and symptom diary and bring it to your next doctor visit, your next dietitian visit, so that they can try to help you identify patterns. That food and symptom diary is really key. And with IBS, I think for tracking purposes, tracking your symptoms involves tracking your stool consistency. So some people don't like to talk about poop, but we're going to do it here. This chart is called the Bristol stool chart. It is a good way to track your symptoms. So whether you have diarrhea or constipation, you can just write, type 2 after this or at this time on this day, and you can track it so that your doctor can more easily identify your symptoms to help you determine what's going on. And then your dietitian can help you with appropriate dietary interventions. I think it can be one of the hardest things when you have IBS is trying to figure out what is causing your symptoms. And this tracking like this with your food and symptom journal and what type of bowel movements you're having can be a really helpful step. There are a lot of triggers for IBS symptoms, and I have some of them listed here. I'm going to focus on the low FODMAP diet because it is the most evidence-based diet for IBS. But there are some triggers that aren't necessarily as obvious but play a role. And so when someone's working with a dietitian, a lot of times we'll ask about stress and anxiety, or how fatty are your meals, or how large are your meals, or if you're drinking a lot of artificially sweetened drinks or eating foods that use artificial sweeteners or carbonated beverages or alcohol, all of these things can contribute to IBS symptoms. So while the low FODMAP diet is a helpful intervention, these are things that you might want to keep in mind. And again, when you're thinking, how am I going to track this and bring this to my doctor? These types of clues will help. So try to take note of some of these things. This is kind of the same thing laid out a little bit differently, but there's a lot of different interventions for IBS, and Dr. Pinto Sanchez alluded to a few of them. So diet, the low FODMAP diet is only one of them, and it's a great diet for managing IBS symptoms, but a lot of times there are other support systems needed. And so digestive enzymes, laxatives, fiber supplements, medications, behavioral therapies, but all of these should be directed with your healthcare team. So I never tell someone, go take a fiber supplement or go take a laxative unless you have the appropriate workup. And the reason for that is that you don't want to be treating something the wrong way and missing a potential diagnosis of something else. So when Dr. Pinto said earlier, which I think is really good, is like, if you have IBS and you have a diagnosis of IBS, you should have been tested for celiac disease. I completely agree, but that's the reason we don't want to do some of these interventions without the appropriate workup. So please go see your gastroenterologist if you're having ongoing digestive symptoms. As I've been doing this more and more, I realize that there is kind of every single person's treatment plan for a low FODMAP diet looks a little bit different. And it's important to realize that a lot of the lists you're going to see online and a lot of the information that's out there may not be the right information for you as it relates to the low FODMAP diet. So it's a very personalized diet program, particularly because of the fact that it is so restrictive. We really want to make sure that what we're doing is both nutritionally adequate and actually improving your symptoms. So there's no one size fits all approach with the low FODMAP diet. So just as a review, the FODMAPs are carbohydrates that people have trouble digesting. They cause gas and bloating and irregular bowel movements, and it's an acronym that stands for fermentable oligosaccharides, disaccharides, monosaccharides, and polyols, which no one needs to know. But these are the types of carbohydrates that may be more likely to cause symptoms. And some examples of these foods are on this slide, and I'll kind of show some potential tweaks as we go. So wheat, barley, and rye, I know we're not eating those on a gluten-free diet, but it's an interesting tidbit that there's some crossover there between people who have IBS symptoms and people who are on a gluten-free diet, as Dr. Pinto Sanchez mentioned. That's why, there's sometimes a gray area about what's causing symptoms. Onion and garlic, these are some of the biggest triggers that I see. Mushrooms, beans and lentils, dairy, which sometimes people kind of understand that they're lactose intolerant, but lactose is actually a FODMAP, so that can be triggering. Stone fruits, apples, pears, mangoes, cauliflower, and sugar-free gums and candies. This is a big one, and I think kind of one of the, if you think about low-hanging fruit, easy things you can cut out to see if it helps your symptoms, it's these artificially sweetened products because they do seem to cause a lot of this diarrhea that people experience. So there are 3 phases to the low FODMAP diet, and these need to be very structured. So the first phase is an elimination phase of 2 to 6 weeks where we remove high FODMAP foods from the diet. That has to be followed by a reintroduction phase. And the reason for that is that we don't want people to be on extremely restrictive diets for a long time if it's not necessary. And these reintroduction challenges allow us to determine which categories of FODMAPs are actually triggering your symptoms. It is extremely rare for every category to affect a person. Typically, it's only 1 or 2 categories, and the most common ones are the categories with garlic and onion and beans. That's not true for everyone, but those are the most common according to the research we have right now. So we'll reintroduce foods in very structured ways in small, medium, and large quantities, and we'll be having them with other low FODMAP foods so that we're not potentially exacerbating symptoms by trying them with something that is high FODMAP. And we'll track symptoms, just like I mentioned earlier. So we'll talk about timing of symptoms, what you ate, the entire composition of your meal, and when your symptoms started. And we'll do that, and it can take a long time because we want to make sure we're giving people the appropriate response time. So usually it's a challenge day followed by a non-challenge day, followed by a challenge day, a non-challenge day, and so on. And then personalization. So this is where your dietitian is most valuable, and this is where most people don't follow up. And it's really unfortunate because once you go through the reintroduction challenges and you know what categories trigger your symptoms, then what do you do about your diet? And there are a lot of tricks that we can give you. There's a lot of different options out there for recipes, for supplements, for things that are helpful, but we don't know that unless we go through all the reintroduction challenges. So again, we'll say it, a gluten-free diet is not necessarily a low FODMAP diet. And here are some reasons why. There are a lot of gluten-free products that have high FODMAP ingredients that can trigger symptoms. And common examples are like granola bars and other snack foods with inulin, crackers or gluten-free bagels seasoned with everything bagel seasoning because it has a lot of garlic and onion in it. Gluten-free breads that are made with honey or agave. There are some that out there that are not made with these ingredients, but it's something you want to look at. And then legume-based pastas. A lot of the gluten-free pastas that are marketed as high protein are usually made with beans, which is a high FODMAP food. So just because you're following a gluten-free diet doesn't mean you're inherently avoiding some of these high FODMAP triggers. In fact, nowadays, because of the way the food production for gluten-free has evolved, we actually are seeing some high FODMAP ingredients added to foods. So just quickly, some swaps. For wheat, barley, and rye, obviously, on a gluten-free diet, these are not going to be included, but gluten-free grains that are also low FODMAP include rice, quinoa, gluten-free oats, corn, buckwheat, millet. So these are all options and appropriate on the low FODMAP diet and a gluten-free diet. For onion and garlic, you can use things like chives, they have kind of an onion flavor and can be a great option when you're following a low FODMAP diet, or garlic and onion infused oil. There are brands that are garlic and onion infused oils, but you can also make your own. Essentially, this is an oil that tastes like garlic or onion because it's cooked with it, but then they remove the carbohydrates from the oil, and you have a flavored oil that can make your food taste great, but isn't going to cause high symptoms related to FODMAPs. For mushrooms, the type matters, so you can use oyster mushrooms or slippery jack mushrooms. For beans and lentils, you can replace with firm edamame or firm tofu or edamame. For milk and soft cheeses, not every dairy-containing food is high lactose, so you can always buy lactose-free versions of some of the dairy-containing foods like milk or yogurt. Also almond milk, rice milk, hard cheeses, butter, queso fresco, those are all low FODMAP options. For some of the fruits, usually berries and kiwis and citrus fruits are lower FODMAP, so they can be good options. For cauliflower, broccoli, carrots, zucchini, spinach, pumpkin, there are way more than that. I just was picking some that were kind of similar to cauliflower, but actually there are a lot of low FODMAP vegetables. And then instead of sugar-free gums and candies, you can use things that have sugar. Of course, that we want to limit sugar in the diet, particularly if we're a diabetic, but it is a lower FODMAP option from IBS symptoms perspective. But plain dark chocolate, regular gum can be options as well. And this is an example of a gluten-free and low FODMAP diet day. You're welcome to take a screenshot of this. It's pretty basic foods. You'll also have access to the slides deck, a recording of the slides after the program if you want to screenshot this, but in the interest of time, I'm going to keep going. So ingredients that you want to watch out for when you're on a low FODMAP diet are inulin and chicory root fiber. As I mentioned, these are in a lot of granola bars and cereals. High fructose corn syrup is very high FODMAP because fructose is a FODMAP category itself, and high fructose corn syrup is very concentrated amounts of fructose. So be aware of that. Garlic and onion powder, they tend to sneak into things, and these are actually really concentrated forms of garlic and onion. So sometimes people have a stronger reaction to garlic and onion powder than they do to the vegetable themselves. Honey, which is sometimes in baked goods or granola or sauces, sugar alcohols, I talked about sugar-free foods and gums, and then dried fruits, especially things like dates, dried apples, pears, and prunes. Those can be triggering for symptoms for sure. I'm always going to advocate for working with a dietitian when you're on a low FODMAP diet, simply because this is so complicated. I am giving you a very small overview of what the low FODMAP diet looks like and what high FODMAP foods are. There are hundreds of foods that have been assessed for FODMAP content, and it is really impossible to squeeze it all into a short presentation like this. So your dietitian is the expert on what the high FODMAP foods are, what foods are appropriate for you to include in a low FODMAP diet, and how to navigate that in the context of what your diet and lifestyle typically look like. So just a few reminders, not every GI symptom is related to gluten exposure. You can certainly manage celiac disease and IBS, but regular follow-up with your healthcare team is certainly indicated just because of the complexities of navigating multiple diets. And Monash University is a great resource for low FODMAP diet information. This is a screenshot of their app. This university does the most research on the low FODMAP diet and the foods and what their FODMAP content is. So it's a good resource. They also have some other things in there to help you get started. They have a food diary option. They have dietitians who are specialized in low FODMAP. And so it's a good resource for you if you're starting to learn more about this. Okay, and I know Vanessa is here, but I will just quickly go through her section because I want to make sure you see this amazing recipe she created. So we have a crispy quinoa and roasted green bean salad here for you today, and I will play the video so you can watch.
Welcome to the kitchen, and thank you to our speakers for those great presentations. So today we are making a fantastic spring salad that is low FODMAP and friendly for IBS. This has some great ingredients in it that really boost nutrition. It can be a side dish. You could serve it as the base with protein on top. There are so many uses for this salad. So the big craze right now is this crispy rice, to put it in salads, to make sushi rolls at home. Today we're going to do a play on that by using quinoa. So quinoa is packed with nutrients. It is considered a super grain. And so we're actually going to toast the quinoa to give that crunchy texture to our salad and pair it with some great green vegetables. We'll have some roasted green beans. We'll have some scallions, only the light greens and dark greens, none of the whites. We know those are not good for the FODMAP diet, the low FODMAP diet, some basil and some edamame. What's really important to think about with this recipe is portions. So we don't want to go out of control with too much edamame on the low FODMAP diet. So we've been very careful. We're using 1 cup that's distributed across 6 servings. So don't go doubling or tripling the amount of edamame that you're going to use in this recipe. All right, so to get started, I have my quinoa here that I already cooked. You're just gonna steam quinoa according to package instructions. This is 1 cup of raw quinoa that cooks down out to about 2 cups of finished quinoa. So I'm adding just a tablespoon of low sodium gluten-free soy sauce and a tablespoon of toasted sesame oil. This is just gonna coat our quinoa for cooking. So I'm gonna give it a good stir here to make sure it's all nice and coated. And then I'm going to spread it out on a baking sheet that's lined with parchment paper. We're going to spread it out into a nice thin layer so that we make sure it toasts evenly in the oven. So just spread it out here on your tray. This is going to cook for about 20 minutes at 400 degrees. What's really important is that you keep stirring it. So maybe every 5 minutes or so, give it a nice shuffle so that it doesn't burn and it gets toasted on all of the different corners. All right. So now for our green beans, this is so simple. We're just gonna toss them with a little bit of olive oil and a pinch of salt. I got this handy dandy new contraption. It's an olive oil sprayer. You could measure out about a tablespoon of olive oil or just wing it. We're just doing a little bit. Again, we don't want them overly covered in oil. And then just sprinkle a little bit of salt over the top. All right, so these are ready to go in the oven. The green beans are gonna roast for 10 minutes. I'm gonna take those out because we don't want them to get overcooked or mushy. We want them to have a little bit of crunch left to them, and we'll leave the quinoa in for a little bit longer. While the quinoa is toasting and the green beans are roasting, we're gonna go ahead and make our salad dressing. In my measuring cup here, I have some grated ginger. I just took a piece of fresh ginger and grated it using a microplane or a zester. It is so fresh, so delicious. Always use fresh ginger. Don't use the one that's frozen. Buy it fresh. It's very, very, very cheap, about 30 cents for a small piece. So use the fresh. To the ginger, I am going to add, this is 2 tablespoons of tahini that I will go ahead and add in. Tahini is just a sesame paste. Then we have 1 tablespoon of toasted sesame oil. This is rice vinegar, seasoned rice vinegar. Again, all vinegar except malt vinegar is gluten-free, so this is perfectly safe for celiac disease. We have some maple syrup just to sweeten it up a little bit. And some low sodium gluten-free soy sauce. And finally, to give it just a little bit of acid, we have some lime juice. This is just 1 lime that we're gonna squeeze on in here. Get all the juice out. And that's all we have to do for the dressing. Just whisk it on up until you get it nice and emulsified. And we'll just let this sit aside until we are ready to assemble our salad. All right, so our green beans are out of the oven, our quinoa is out of the oven, everything has cooled down a little bit so that I can touch it. So to start, I'm gonna chop up these green beans into bite-sized pieces. Again, this is not like a magical, like perfect culinary technique. We just wanna make sure that you can easily take a bite of the beans as part of your salad. So just give them a little bit of a chop. You know, they're an inch and a half. Doesn't have to be perfect. And then we'll start tossing them into our bowl. And remember, I only cooked these for about 10 minutes because I wanted to maintain that crunch. They can get soggy very, very quickly, and so we don't want them to come off as though we steamed them. So don't overcook the green beans. All right, there we go, the green beans. Now we have our cup of edamame that we'll go ahead and put in. These were frozen and I just steamed them in a little bit of hot water to get them nice and soft. As I mentioned earlier, we have our scallions here. We only have the dark greens and the light greens, and I chopped off the white parts of them. Those are not friendly to the low FODMAP diet, so we don't want to have those in there. Just give these a nice little chop as well. I like to chop them on the diagonal, but however you like to chop them is absolutely fine. All right, we'll just toss those right in. Now we're gonna add in our crispy quinoa that has cooled. There are probably lots of techniques to do this. I like to just fold up the parchment paper. Makes it for an easy carrying device. Put it right on top. And now we're gonna finish it off with our fresh herbs, which are my favorite part of any salad. So this is just some fresh basil. Now, how I like to chop basil, just bunch it all up, roll it a bit, so you've got a nice pile, and then just roughly chop it. If you wanted it to be pretty, you could roll it nicely and have a chiffonade. But again, this is all gonna get tossed together in a salad. So I'm just giving it a nice rough chop. All right, we'll top it with our basil. Last but certainly not least, the delicious sesame ginger salad dressing that we made just a few minutes ago. Give it a nice stir. and pour it over the top. All right, grab our salad spoons and toss it all together. And there we go. You've got our beautiful spring salad with roasted green beans and toasted quinoa and a sesame ginger vinaigrette. I hope you enjoy it as much as I will.
All right. Well, that does conclude our second culinary medicine webinar of 2026. We unfortunately do not have time to answer any questions since today's session was packed with so much great information. Megan, I don't know if you're able to share your screen again, but if we could put those post-survey QR codes on the screen super quickly, just so we can get them out to folks. I will also drop those links in the chat. If you could please just fill these out, whatever survey applies most to you, these help us improve our programs moving forward. And again, I also just put these links in the chat. Right. And if we could just go to that next slide again, just with that final information we can show for continuing education. Again, if you have any questions about this, please don't hesitate to reach out to me. Once you register with Boston Children's Hospital, you just text that code to that phone number, and then your attendance will be recorded. But thank you all so much again for joining us today, and thank you for our panel for your time and your expertise on celiac disease and IBS. We certainly hope that you will join us for our next culinary medicine webinar on powering the gluten-free athlete, energy, endurance, and recovery, which is going to be scheduled for Tuesday, June 2nd, I believe, at the same time, 3 p.m. Eastern, 12 p.m. Pacific. And we also hope to see you at any of our other virtual education sessions that we offer too, which you can see all of those programs we have available at celiac.org. But thank you so much, everyone, and we hope you have a great week.
Thank you very much.